We'll now move into the rapid presentations, and I'll invite John to come up to the stage. Associate Professor John Wentworth is a clinician scientist who doesn't need to use stairs within the Population Health and Immunity Division at WEHI. John leads several multinational trials, including Type 1 Screen, TrialNet, and several immunotherapy studies for the newly formed National Trial Network, ATIC. Thank you, John.
Thanks, Megan. And presumably this button works to get the slides forward. So 5 minutes about Type 1 Screen. We established ourselves in 2019 in response to pretty savage TrialNet funding cuts and with JDRF support. And initially we set up the standard serum collection in the community, shipped to Melbourne in the standard islet autoantibody assays. But more recently, about a year ago, we transitioned to do it yourself in the home and using the PCR-based agglutination PCR antibody assay, which we've had very, very good results from, which I'll show you. And we've changed our inclusion a little bit. We've gone to, we're not ageist, so we're happy to take people over 2 years of age in our program. And we're doing all right. We want to do better, and the biggest problem we have is resourcing and getting the message out, because the thing that drives recruitment to these things is media and mail-outs directly to the affected population. The clinicians still are a bit behind in terms of wanting to offer this to their patients. The majority of our samples so far have been on venous, but as you can see, we've had a blip there in the end of 2022. That's when we transitioned to in-home collection. And we've recently done a campaign, and we've had 1,000 registrations over a course of a month, and we're just waiting for those samples to come in now. You can see that we're screening all over Australia. It's roughly reflecting the population distribution, so most screens in Queensland, Victoria and New South Wales. There's the age distribution, mostly kids getting screened, but I managed to get Santa, who was a relative, at one of the family days there, and certainly we don't have an ageist approach, as I said. And then the real, the money slide, or the money bit, is, you know, who are we finding and what are we doing? We're seeing about, as you would expect, about 5% positive screens, one or more antibodies, and the majority of the positive screens are actually multiple antibodies, and you can see there that we've got a spread, in most of them stage 1, but we've got a few in stage 2. The monitoring, we're really not resourced to do that. We're doing the best we can, but that's a major piece of the puzzle that we need to fix, and we've got some ideas for that. Now, this is a really important slide. So this is a summary of how the blood spot is working. So on the first 3 columns, you've got the results of the 3 autoantibodies we measure in blood spot. We've since added zinc, and zinc is also working well. But for these initial screens, and we're still waiting to get confirmation on the zincs that have come through that we've just recently diagnosed. But the point here is that if we call positive on blood spot, it is positive on serum. There are some indeterminants that are the yellow boxes there. I can't call them negative. I get someone to have a draw. Sometimes it's positive, sometimes it's negative. And there are a few samples still we're waiting on there. But essentially for now, we've got a highly specific assay. We've also recently completed a validation study where we had a formal prospective cohort of a lot of positives and negatives, and again, that looks really good. We'll submit that shortly for publication. So we're on a roll. We do want to do a few things moving forward. We've got another year of funding from JDRF, and in that time, I think we are a chance of actually accrediting the agglutination PCR assay with the help of our colleagues at the Children's Hospital in Melbourne. We do want to drive screening activity where resources permit, and the monitoring is the major stumbling block. And I think a critical need in the short term is for us to work out, like screening remotely, to actually monitor remotely. And we've got ideas on how to do that. And that to me is an important thing that we need to do in Australia. And there is the acknowledgement slide. Clearly the participants and their families who've come along on the journey are very important. Thank you to JDRF and a number of the other funders. Thank you very much. And I should say, sorry, I managed to get the screening kits through security. I'm going to pop them next to the Mentos on our table. So if you want to sample one or take them back to your clinics, please do.
Thanks, John. Our next speaker this morning is Dr. Kirstine Bell. Dr. Kirstine Bell is a Senior Research Fellow at the Charles Perkins Centre at the University of Sydney and is the Principal Research Fellow leading the Australian Type 1 National Screening Pilot, which I'm sure you'll talk to us about today.
Thank you so much. So again, I'm going to give you a 5-minute overview of what we're doing with the National Screening Pilot. I'm going to start with our vision, and this is the big vision for everything. But what we're looking for, or to the future, is for a routine, publicly funded national screening program for all children for type 1 diabetes. So this is general population screening, the same as we do immunisations for all kids. We do bowel cancer, breast cancer, cervical cancer. This is the new childhood type 1 diabetes national screening pilot. In doing that, we have to start small, and we need to start with a pilot. But everything that we do, we're guided. We want it to be realistic. We want it to be scalable. It has to reach a nation. It has to be sustainable. This isn't a one-off thing. This is for life. It has to be equitable. We need to reach all people. And it has to be considered cost-effective. If we make it too expensive, we can't prove that the benefits outweigh the costs, and the government won't fund it. So we have to keep all of these things in mind in how we design and deliver right from the get-go. So the first challenge that we wanted to focus is, what is the optimal screening model for type 1 diabetes? So you've heard a little bit about antibody screening, we've heard a little bit about genetic risk, and so there's a number of models that have been implemented highly successfully overseas. And we needed to figure out what's going to be the best in the Australian landscape and for the Australian population. So define best in a couple of ways. The first is to think about what's feasible and acceptable to the population. So we have a feasibility acceptability pilot trialling screening in communities. We've got 3 different screening models, and I'll go through those in a second. The second is a health technology assessment and an economic modelling. So this is evaluating the evidence in terms of safety, clinical efficacy, and also the cost effectiveness in an Australian budget. And coincidentally, smartly, these first 2 aims are the same strategy that the government took when they did the National Bowel Cancer Screening Pilot. So they had a local pilot to look at implementation in Australia, but then they took the international evidence base and they did a modelled economic evaluation to figure out what was cost effective. So we're using a very similar approach. And thirdly, and importantly, aim 3 is around our stakeholder engagement, and that's it, considering the preferences, the barriers, the opportunities at all levels. So the community, clinical, political, industry, health professionals, what does everyone think? What's their preferences, and how would their considerations for rolling and participating in something like this? So, as I said, there were 2 key models, and I said we were comparing 3. So how does that maths work out? We have the first 2 on the left are a genetic risk stratified approach. So we're looking for those who have a higher risk and then targeting the follow-up to them. And so we've got 2 ways we can actually do that genetic risk stratification. One is aligning with newborn screening. So kids in Australia, 99.9% of newborns are already getting a heel prick at birth to look for other metabolic conditions. We can use that same dried blood spot to evaluate their genetic risk of type 1 diabetes in the general population. 10% of kids, if we use that threshold, will be flagged as having an increased chance, and that will capture about 80% of future cases of type 1 diabetes in that 10% of kids. They can then be offered targeted ongoing screening through antibody using the same dry blood spot that John Wentworth just introduced. So it's a very minimally invasive ongoing at-home test that they can do to monitor progression for antibodies. The second cohort starts very much the same genetic pathway, but the alternative is, rather than doing a newborn dry blood spot, we can do it with a saliva swab at immunisations at 6 or 12 months of age. So as long as we have that genetic risk, we can still follow that same pathway before the age of 1, and that DKA benefit we know is the highest in those younger kids. So there's that benefit starting really early. The third cohort bypasses all of that genetic risk stratification. It continues straight through to antibody testing for everyone. And as Marion very kindly introduced, the optimal ages are potentially 2, 6, 10. It may be just 2 ages, 2 and 6, it may be 2 and 10, but we have feasibility, acceptability data on all of those kids. And the challenge there is that we don't have a routine draw or a visit, so looking at how do we actually access those samples. And so one of the options that we're looking at now is in-school testing. Same as we have national vaccination programs in secondary school, we have eyesight testings in preschools. Can we do something in school for all kids? Okay, I said this is a national pilot, so we do want to make sure that these catchment areas aren't state specific. So we have very small catchment areas. It's literally a few suburbs in each area because we want to screen every eligible child. We're not trying to cast a wide net and get a child here and there. We want every kid in that community screened for type 1 because that's how a national screening program would work. So our newborns are at our Sydney hospitals in Adelaide. Our infants doing a saliva swab in Brisbane, North and Western Sydney, and our 2, 6 and 10-year-olds doing a finger prick are in northwest Melbourne and southeast Perth. I'm going to give you a very quick snapshot of where we are. Note, these cohorts haven't been running at the same intensity and the same duration, so don't compare numbers just yet, but I wanted to give you a snapshot to show that we've got 2,200 newborns, we've got 1,600 infants and over 1,300 children who've already been registered for screening. So you can see that in the general population there is appetite for screening, they do sign up. Cohort 1 has currently closed, and we had 90% of mums who were approached about screening said yes. So their appetite for screening is there, it is acceptable, and we'd love to follow those kids through now and find out more about their surveys, from their surveys, how they feel about screening and how their journey progresses. And you've seen from John, we've already got some cases of type 1 detected. So I'm standing here on behalf of a huge team. This is our CIs on the project, but we also have a huge team, the coordinating centre in Sydney, so Shannon and Cara are here today. We also have a huge community group, so we've got those who have a connection to type 1, but we have a separate group for no connection to type 1, representing more of a general population, and they are invaluable for helping us co-design this project. And lastly, so we've got a website and a helpline. So the helpline is staffed. We've got genetic counsellors, credentialed diabetes educators, as well as the research team on that helpline who can support health professionals and families. And we've also got the comprehensive website. But thank you very much.
Thank you, Kirsty. Our third speaker in this session today is Associate Professor Emma Hamilton-Williams, and she is the Group Leader and Principal Research Fellow at the Fraser Institute, part of the University of Queensland. Emma's career focuses on understanding how immune tolerance is disrupted, leading to the development of autoimmune disease and type 1 diabetes. So thank you, Emma.
Thank you, Megan. All right, so I'm really interested in the gut microbiome, and could we target the gut microbiome to prevent type 1 diabetes? So you've heard a lot about different possible triggers and preventative factors that might be either starting off T1D or things that might be missing that we need to re-establish. So the microbiome, so something in the microbiome is likely to contain a protective factor that might be missing in those that progress to T1D. So what could that be? So most of the best evidence that we have from lots of different cross-sectional studies and from the longitudinal TEDdy study suggests that there might be a depletion of bacteria in the gut that ferment fibre to produce metabolites called short-chain fatty acids. So what are short-chain, what are short-chain fatty acids? So these are acetate, butyrate and propionate are the most common ones, and they have many beneficial effects on the gut barrier, but also on immune tolerance. So with funding from JDRF and kind of as a follow-on from a great leadership program that JDRF was running, we put together a collaborative trial to investigate whether a particular dietary fibre that supplemented short-chain fatty acids might be beneficial in the case of T1D. So this study was a very small pilot study looking at the feasibility and safety of delivering this. We wanted to know, first, was it feasible and safe? Did it change the microbiota? But also to look at some investigations as to whether we also changed the immune response or glucose control. So the prebiotic fibre is called HAMS-AB. So it's a resistant starch, so it's a fibre, but it's modified with addition of acetate and butyrate, these short-chain fatty acids. So when that is taken and consumed, there's a big payload of those short-chain fatty acids delivered to the gut. So this was originally developed or shown by Dr. Eliana Marino in a mouse study that if you gave this HAMS-A-B combination, when you gave the A and the B together, it almost completely prevented diabetes progression in NOD mice. So could this then be applied in people, was our study. So what did we do? So we had adults with long-standing T1D that took HAMS-A-B daily for 6 weeks. They took 40 grams a day, and we looked in their stool, their blood, and their glucose control measures. So this study has been published. I don't have time to go through all the data. Kirstine Bell, who you just heard from, led the clinical aspects of the study. My team led all the microbiome studies, and many other people contributed to lots of different parts of it. But just to summarise what we found, so our key findings were, yes, we changed the gut microbiota, yes, we increased short-chain fatty acids, and interestingly, the higher levels of butyrate control correlated with better glucose control. And we also found particular gut bacteria, in particular bifidobacterium that you heard about from Jenny, also particularly correlated with better glucose control. And when we studied the immune response in the PBMC, we saw markers indicative of regulatory response were also upregulated in the blood after taking this study. So what have I done recently that's a little bit new? We wanted to see if we could actually make a causal link between the microbiota changes we found in these people and protection from diabetes. So to do this, we made a human microbiota transfer model. So we took the microbiota, the stool bacteria from those people from the trial, we colonised it into germ-free NOD mouse, and then we looked to see if it prevented or delayed diabetes. So we did this with 4 different individuals from the trial. We took 2 that we called responders and 2 that we called non-responders, and we colonised their stool, either their baseline stool before the diet or the 6-week stool after the diet. So this is how we did it. So we put those stool samples into NOD mice, and we did it like a model of maternal protection. We colonised it into the mothers, let the babies be born, and we studied the diabetes in the offspring. So then what was the result? And the left side is the result from the mice that received the baseline stool. So neither the responders or the non-responders delayed diabetes compared to the control germ-free mice is the black line. But if you look in the right-hand side, if you colonise the bacteria from the responders, so those were the stool from the people that took the HAMS-A-B after the diet, that delayed diabetes compared to the non-responders. So that suggests whatever change we made to the microbiota in the people was actually able to protect from disease. No, I didn't put other slide. And also, in the mice, the responders, those mice also had higher butyrate levels as well. So it did correlate with butyrate, or at least those mice had more butyrate as well. So I think that's all I have time for in 5 minutes. So many people were involved. As we mentioned, this was a collaboration with Eliana, with Kirsty, Sonia and Esteban in Belgium, and all the members of my team. So thank you.
Thank you, Emma. So our final speaker in our session today is Dr. Ki Wook Kim. Ki Wook is a JDRF Career Development Fellow based at the University of New South Wales. He leads the Human Viromics Research Group within the UNSW-affiliated Virology Research Laboratory at the Prince of Wales Hospital. And he also co-leads the virology theme within the NDU study. So thank you, Ki Wook.
Okay. Thank you. I'm speaking today on behalf of the virology theme in India, which I co-lead with Professor Maria Craig and Bill Rawlinson. And thank you, Marion, for very elegantly spoiling my talk. But we know from many studies that there's a whole host of environmental factors associated, but time and time again, viruses are popping up as a prime candidate trigger for autoimmunity and type 1 diabetes. Among the different viruses that have been associated, enteroviruses by far have had most evidence towards them, lots of studies, and really almost a century of work has associated enteroviruses. So enteroviruses are RNA viruses. They're very ubiquitous. They're rapidly replicating, and they're very diverse. In more than 100 different human enteroviruses have been discovered and characterized to date. And here you can see, as Mary mentioned, enteroviruses enter the beta cells through the CAR receptor. And here you're showing human pancreatic islets in vitro infected with Coxsackie virus B5. So 5 days later, you lose this insulin production. VP1 shows the virus that has expanded throughout the islet. So I don't have time to summarize all this, but there's large meta-analysis and systematic review that we've done, as well as others. And most recently, Sonia Isaacs, our PhD student, has completed a very comprehensive meta-analysis. And so there's undeniable association between enterovirus detection molecularly with IA and T1D. So these are the clinical trials that have just completed or currently undergoing. So PRV-101, it's actually a pentavalent. They dropped the CVB6 from that because it's very rare in the population. So it's either a whole virus approach or there's a VLP, so structure protein, a VLP virus-like particle-based vaccine that's being developed. There's also some antiviral drug combinations being trialed. So these would be, I guess, relevant for secondary prevention, and some repurposed drugs are also part of that. So with enteroviruses, so if you look at the history of how we detected viruses, it's been very targeted. So when we set out in the NDA study, as well as in the TEDI, there's concerns about very focused investigation bias towards enteroviruses. So were we doing tunnel vision? So we're at this era where we can screen for all viruses that are infecting humans, so hence we call that the human virome. So in India, what we did was use virome capture sequencing. So it's a large comprehensive probe set of 2 million probes, and then all complementary sequences that are virus sequence encoding, we captured and then sequenced. So we're currently finished the gut virome sequencing. We've moved on to the respiratory virome sequencing. And also what we're doing in the plasma sample is using a technology called VerScan, which is an application of FIPSeq to look at antiviral antibody repertoire in these children in India. So what about COVID? India is one of the unique cohorts that have been following throughout the pandemic. So this is ongoing research that will be addressed in India. So thank you, everyone. It's a cast of the thousands, and mostly the study participants. Thank you.